Come on now. So you've been studying. Test is Monday, 2 days. You feel like you understand everything? Need anything re-explained? Nobody?
I've been studying, but I don't have like a specific question, so I'm just kind of seeing what anybody else is struggling with.
Okay. Fair enough. So anyone else struggling with anything? Nobody's struggling? Really? So you feel like everything's clear? GTG, good to go? Okay, so name some conditions that would fall under respiratory alkalosis.
Like hyperventilating of mom in labor, or panic, anxiety attacks.
Okay. Any others?
Like asthma for the panic attack from initial, like not able to breathe well.
Right. So did you all get the PowerPoint? Okay.
Mm-hmm.
Okay, cool. Did you do some of the practice on the PowerPoint?
Honestly, not yet, but I will do that.
Hilarious.
Throw that out there.
Hey, I mean, there's nothing wrong with a little bit of honesty. The one thing I don't want you doing is the night before a test, like feeling like you have to do a bunch of hardcore studying, because that would be a hot mess. You won't remember any of that. So hopefully by now you have a good grasp on the things that you need to do. So I think the acid base, you probably figured most of that out, you know, using just the basic rules of it. But you do need to know, just, you know, because the question can come in any form. They could actually give you an ABG, or they can give you a condition and say, you know, what likely condition is this patient in? And so I would hate for you to kind of hit that stomped mode and not know what to do.
I do have a question.
Yeah.
So I was doing some practice questions, and it was talking about one would like a pulmonary embolism cause between like an acid base imbalance. Couldn't it cause both, like a respiratory acidosis from blocking like CO2?
Like over time, but usually the first thing they're gonna have is chest pain and shortness of breath.
Okay. So that would fall under the respiratory alkalosis side more?
In the beginning. And then if that's not resolved, then toxins, because remember, we can't get blood flow to the pulmonary capillaries. And if we can't get blood flow there, then what ends up happening is, although oxygen's there, we don't have a vessel to carry the oxygen to the rest of the body. Does that make sense? So as you start moving into your more dire stages of pulmonary embolism, and it is missed 66% of the time. So then those individuals will end up at that point in respiratory acidosis. Acidosis at that point, because now they won't have a way for that blood flow to reach other tissues distally. So when you were doing the questions, what were you concerned with?
I guess whenever I was thinking through in my head that if there's an emboli within the lungs, that it's going to block, my mind went straight towards blocking CO2 coming out of like the area wherever the emboli is. So I picked respiratory acidosis, but it actually fell under respiratory alkalosis as the correct answer.
Right. It's not the CO2. You're going to end up with a buildup of CO2. So that's why over time you will end up with the acidosis. But initially, it's going to be alkalosis. So that's a good question. That's a good one. All right. So we have panic attack. We have PE initially. What would we have? Fear, mechanical ventilation,
Anxiety.
hyperventilation, the laboring mom. We talked about all of that. So give me some signs and symptoms that, they would normally have.
So the
Ventilation.
We're still on respiratory alkalosis.
So their heart rate's going to be going fast because of the fast respirations.
Okay.
And
So
then they're going to be a little bit like lethargic and maybe lightheaded or dizzy.
okay. So rapid breathing, hyperventilation.
Tingling in the extremities.
Say that again.
Tingling in the extremities.
Yes, and for those of you, as I talked about before, giving birth, and those stages when you're really panting, and that's why they try to do that rescue breathing, or not rescue breathing, but the breathing techniques. That's why they do that, because your fingers will actually turn numb and they will tingle, and you can end up with carpal pedal spasms. So that's where now your fingers look more contorted than their normal position. And that's because of all of the lack of CO2 in the body system. Okay. So I tried to add in some of those little pictures that would actually give you the conditions as well as how the patients would present. So that way, you had both pieces. When you look at, and that was also, Marky, if you go back to it, there was a slide in there and it had an arrow when it was just talking about causes of alkalosis. In the top left corner, it actually talked about the hyperventilation results in respiratory alkalosis, anxiety, high altitudes, pregnancy, fever, hypoxia, and then it said the initial stages of a PE.
Okay.
So it's in there on that slide. And on the bottom slide, if you look at the metabolic component, then this would be someone that's losing gastric juices. So they would have an NG tube, right? Vomiting, diarrhea, someone that's using a lot of antacids. So whether it's Tums or Rolaids or the baking soda, it's all the same. The other thing is potassium wasting diuretics, which would be your Lasix. So that would also cause, that would be metabolic alkalosis. So what would you expect to see in that individual as far as signs and symptoms? How would they present?
For metabolic alkalosis?
Right.
They're going to have the hypoventilation.
Okay.
Low potassium counts, so possible dysrhythmias.
They could have some dysrhythmias. Why would they have abnormal, irregular, or an abnormal heart rate? What's the real cause of that happening?
The potassium deficiency.
Because they have hypokalemia, and your heart doesn't like anything for which the potassium is too high or too low. So it's specifically when potassium is really low, you can start seeing what they call premature ventricular contractions related to that. Numbness and tingling of the fingers, and actually if you have low potassium, that's when you get those cramps in your legs like the Charlie horses. That's what that's from, is because your electrolytes are depleted. So if you drink some Powerade or Gatorade or K10 or something like that, then it usually pops that right back up. Again, MVD, nausea, vomiting, diarrhea, confusion, so dizziness, irritability. Those will all be some signs and symptoms you would see with metabolic alkalosis. But if you have excessive GI suctioning, so that would be someone where they have the NG tube in, the suction's going, but it's not intermittent. Okay, and it's up at a higher millimeter of mercury. All right. So let's go to the acidosis side. One other thing that will fall under, before we switch to acidosis, that will fall under metabolic alkalosis is a pediatric condition called pyloric stenosis. So basically the pyloric sphincter is narrow, and that the hallmark sign for pyloric stenosis would be projectile vomiting. So, and they're going to literally be spewing vomit. So it won't be a little bit, it'll be a whole lot. So from that standpoint, they would be on the metabolic alkalosis side. Does that make sense?
Okay. I'm sorry, can you repeat? My son was yelling when you were talking. If you could please repeat the beginning part. You said it was called what again?
Pyloric stenosis.
Okay.
So, you know, from when you're the esophagus, then you have at the lower esophageal sphincter, you have a pyloric sphincter. So that pylori is actually going to be narrow, and it's going to put a lot of pressure on the stomach, and the baby will have projectile vomiting. So when I say spew out, it'd be almost like water hose. And you're going to wonder, how could a little baby that small put out that much vomit?
Okay.
So, but again, vomiting falls under the metabolic alkalosis side. So that I just wanted you all to be aware. And we're going to talk a little bit more about pyloric stenosis with fluid and electrolytes. Because of that projectile vomiting, then you're going to have a lot of volume depletion. But I know I don't know if Miss Pritchett mentioned that the other day. I know she and I talked about it, but I couldn't remember if she had mentioned it or not. All right, on the acidosis side. So this is where the pH is actually less than 7.35, right?
Mm-hmm.
Okay. So looking at respiratory acidosis, then that would be anyone that's actually retaining CO2. So a person that's hypoventilating, a drug overdose, more specifically narcotics, later stages of pulmonary embolism, but this is more specifically pulmonary edema, so that's somebody that's in heart failure, chest trauma, and neuromuscular disease. So that would actually cause hypoventilation. Any others? There might be one I didn't mention, or two.
I mean, just respiratory failure in general.
Okay. How about airway obstruction? That would fall under respiratory acidosis. You get something stuck in your throat, you're not going to be able to get any oxygen in, and you're not going to be able to get any CO2 out, right? COPD will fall underneath that.
All of our gas exchange exemplars, pretty much.
Huh?
All of our gas exchange exemplars, pretty much.
Exactly. So on the metabolic acidosis side, so your aspirin overdose, DKA, shock, sepsis, severe diarrhea, and renal failure. So those would all fall underneath there. So the causes to all of those things, if you're looking at respiratory, is going to be hypoventilation and impaired gas exchange. From metabolic, it'll be from the diabetes, hyperkalemia, and then lactic acidosis. So all of those would cause you to have some type of acidic, whether it's respiratory or metabolic. So let's go and start with respiratory like we did on the alkalosis side. How would the patient present? What would be your signs and symptoms?
Your respirations would be less than 12.
Okay.
Confused. As an acidosis, it has the high potassium, so risk for dysrhythmias.
Okay. So if you're hypoventilation, if you're having hypoventilation, if you're hypoventilating, then your patient's going to be hypoxic, right?
Mm-hmm.
Okay. So your patients will be hypoxic. So their respirations will be rapid but shallow. They'll have a drop in their BP. So they'll be short of breath, hyperkalemia. There's a difference. And then we'll have whatever cardiac arrhythmia is related to the hyperkalemia, right?
Mm-hmm.
Muscle weakness, hyperreflexia, those will all be some potentials or signs and symptoms that could be experienced. So, if they give them too much anesthesia, or if the patient self overdoses on narcotics or anything, heroin, anything that's opioid driven, then it's going to suppress respiration. Pneumonia and atelectasis would fall under respiratory acidosis as well.
Mhm.
Is tachycardia associated with all the acidosis conditions?
We didn't talk about tachycardia here.
Sorry, I was just looking at my notes and I noticed that. And I didn't know if it was just specific for metabolic acidosis or for all of them.
No, it was on metabolic acidosis, because if you are hypoventilating, then your heart probably is not beating fast.
Okay.
Okay. Usually what your lungs are doing, your heart's a part of that. Does that make sense?
Yes.
Okay. All right. Let's see. Let's see if there's any others. We did respiratory, metabolic wise. All right. So what would be some of our signs and symptoms that we would see with metabolic acidosis?
Cosmal respiration?
Say that again.
Cosmal respiration?
Oh, Kussmaul's. So Kussmaul's respirations, what is that? Is that like deep and rapid?
Yes.
Okay. And who usually has Kussmaul's respirations?
The DKA patient.
Your DKA patients. So remember a couple weeks ago, and even last week or this past week, when I said certain conditions you see, you should immediately know what their acid-base imbalance is. Okay? Changes in LOC, they can be confused, drowsiness, have a headache, blood pressure is low, muscle twitching, but there's a decreased ability of the kidneys to excrete the acid or to conserve the base. So that would be your DKA, severe diarrhea, renal failure, and your shock people. Okay? All right. So, try to keep those into perspective, because when we hit class on Tuesday and we start talking about the hypers and the hypokalemias and all of that, that's going to be like, I'm tired. Be quiet. But kind of have an idea that, where those acids are shifting to and moving. So any questions about the earlier material, your COPD, your asthma, pneumonia?
I have a question about tactile fremitus.
Okay.
When you place your hands on like the patient's back, and abnormal finding, like if they have increased secretions in their lungs and you have them say 99, 99, 99, is it to where you don't feel the vibrations because of the mucus?
Correct. Because if you take your family member, your kiddo, your husband, anybody, and you put your hands on their back and they say blue moon or 99, you should feel some vibration in your hand. If you don't feel that, then there's some consolidation somewhere in the lungs. So normally you should feel the vibration. Abnormally, no vibration. Make sense?
Mm-hmm.
Okay. So that was a good question.
And then I have another question.
Okay.
So with chronic bronchitis, I understand that there's adequate perfusion to the alveoli, but it's where the ventilation isn't adequate. Is that right? Because there's the VQ mismatch.
Right. What happens is we get oxygen in, but we can't get CO2 out. So we have perfusion, but because even though we get the oxygen, what comes back is more CO2. So we end up with an imbalance of oxygen. So that's why the the skin color is a bluish color because we don't get all of the oxygenated blood to where it needs to be. So if we're retaining CO2, then that's going to make our O2 levels upside down. Does that make sense?
And these patients feel like they have to take another breath in just to try and get all the CO2 out. So I think you mentioned maybe the last webcam call that we had that the pursed lip breathing is really specific for emphysema patients, but wouldn't that be also a breathing technique for chronic bronchitis?
Completely different process because they have a lot of dilation and of their alveoli and bronchial tract. So those alveoli that's a lot more defined, a lot more more circular in nature, they will kind of blend together and just be one big blob alveoli versus all the little individual ones. So that usually for COPD people, they do not use pursed lip breathing.
For chronic bronchitis?
Correct.
Okay.
So that's only usually seen in emphysema.
Okay.
Although, and the reason being is although they both retain CO2, with emphysema, they're losing alveoli and vasculature. So the loss is equal. It's not, we don't have an upside down loss. And that's why the pursed lip breathing actually works to help keep the alveoli open, whatever's left of the alveoli.
Okay.
Okay. So what about your aspiration pneumonia? Are you good with that one? Knowing how it happens, you know, the acids get into the lung system, which isn't good, right?
Mm-hmm.
Okay. And then we know about our pneumonia. So I've actually covered that one pretty clearly. I don't know if there is a question, but.
I mean, feel free to ask if you've got them. I mean, I don't know if I've got a question, but I don't know.
Well, you remember, kiddos are usually more viral, but they can have bacteria.
And the only
can have viral, but they primarily have bacteria, and your immunocompromised usually have your bacterial or fungal.
And the one way to just clarify or test is the sputum culture. Right.
So they're not going to know what's causing the problem until they actually do a sputum culture. But remember, elderly people present differently when you're looking
have the temperature
at pneumonia, because they have an alteration in mental status. So if you have an elderly person, alteration in mental status, two things you should be thinking: either pneumonia or urosepsis or UTI. So they either have a urinary problem or they have a pneumonia problem. Makes sense?
Mm-hmm.
Okay. So, reasons why people can end up aspirating is, too much alcohol and you vomit, drug overdose, vomit, seizures, vomit, stroke, vomit, head trauma, vomit. These are all conditions. General anesthesia, vomit. That's why it's important if they're NPO, they stay NPO and they don't eat, right? Intracranial lesions, masses, or a clot or anything like that, then again, that can induce vomiting, and that's going to cause, potential for aspiration. So, they could have dysphagia, difficulty swallowing. So there are strictures in the esophagus, cancer. All of those things could be issues that could be associated with aspiration pneumonia. A TE fistula can lead to aspiration pneumonia. Okay. GERD, another one, that gastroesophageal reflux disease, that can cause aspiration pneumonia. Dementia, multiple sclerosis, all of those are potential for aspiration pneumonia. So what would be signs and symptoms that you would see on your patient with aspiration pneumonia?
Shortness of breath, or maybe like coughing, can't complete a sentence.
definitely you'd have some contents around their mouth or in their oral cavity, right?
Mhm.
Okay, so that would be your first telltale sign. Because when you see it, you're gonna be like, okay, this don't seem right. Okay. So let's see. There's two different types. There's a chemical and there's a chemical pneumonitis, which is basically when it's in a specific syndrome. So I'm not going to even bother you with all of that, but we'll just focus on aspiration pneumonia. We'll just stick with that. But impaired gag reflex, coughing, ciliary movement, all of those are going to be the reasons why. Even a hospital-acquired bacterial pneumonia can cause an aspiration. So those are other things to think about. Your patient may, cough up some crap and then it go the wrong way and now they start vomiting and it's a wrap. All right. So what other signs and symptoms besides shortness of breath? What would their breath sounds be like?
Crackles.
Always crackles?
It may be diminished.
Okay, hang on. There's a question. So for pneumonia, before we give antibiotics, do we have to wait until a sputum culture has been collected? It is best to wait for the sputum culture to be collected because if you already start treating them, then it'll be difficult to understand what antibiotic would be the best antibiotic for the patient. So if you have somebody with pneumonia, they would already be coughing. Now, you don't need to wait for the results. You just need to wait to make sure the specimen's been done. And that would really be for anything. So if you're going to be given antibiotics for it, it's like, if you're going to do antibiotics for a UTI, then you need to at least collect the specimen to make sure you have that. But it's always recommended to get your sputum culture beforehand. So that was a good question.
I'm glad that someone asked that question because I had a practice question. And I said I guess my answer was wait until the results came back. And the rationale was saying, as long as you've collected your sample and you can treat it with a broad spectrum, then once the culture and sensitivity comes back, then you can change whatever antibiotic they're on that infection.
Yes, that is true. So you don't have to wait for the results. You just need to make sure that it's been collected. Because the results can take 48 hours. And some hospitals, they wait 5 days before they finalize a culture. So, if you're waiting for long, then that person will be dead. Honestly, true story. A lady had something called mastitis and she got a prescription. She didn't fill it. 7 days later, she was in septic shock. She came in with circummoral cyanosis. She had cyanosis on her cheeks. And she died within 3 hours of getting back to the emergency room. So, if we wait 5 days for that result to come back, that person's going to more than likely be dead. But that is a very good question. So their breath sounds would be decreased. They could have, they could have rails. If they're percussing the breath sounds, then they might have a dull sound when you're doing percussions. If you do that, tachycardia, tachypnea, those will all be signs and symptoms. So purulent sputum, fever, chills, fatigue, achy muscles, some malaise. So that would be all. They could have some pleuritic chest pain. So that's all different types of signs and symptoms related to that.
Is pleuritic chest pain just when they're breathing in, it hurts?
Mm-hmm. So what labs would you be looking for?
Your white blood cell or CBC?
Your CBC, your white cell count greater than 10,000, right? because normal is 5 to 10. So they may do blood cultures just to make sure it's not systemic. Chest x-ray for diagnostic studies. Anything else? You want a sputum culture? For sure. Depending on the situation, they may be super aggressive and do a bronchoscopy, you know, but that depends on if it's like foreign material, foreign body involvement, meaning, you know, something gets stuck and go down the trachea and end up in the lungs. So that patient may have to be mechanically ventilated. Makes sense. And they're going to require some antibiotic, and it's going to be bug dependent, meaning bacterial dependent or fungi dependent. But if most of you have had some pneumonia patients in your clinicals, one of the more common antibiotics that's given is Levaquin or levofloxacin. So they usually use those for pneumonia. I know some of my students have actually had patients on Levaquin. So, all right. If it's fungal, then they're going to give them something some bigger guns, vancomycin, linezolid, that's another one, clindamycin. So they'll give them a whole nother gamut full. They'll need corticosteroid management to decrease inflammation from the toxin that was related to the injury from having aspiration pneumonia. But, you know, pneumonia is pneumonia. Aspiration just means that's how it came through. And then you have regular pneumonia that's not from an aspiration component. All right, anything, so we did that. We did COPD, emphysema. You did the crossword puzzle, right?
Mm-hmm.
So anything out of immunity? So, yeah, I think I covered UTI pretty hard. So I think we should be good. Unless there's other questions. I put the PowerPoint up there, put the examples, made sure that they didn't have any compensatory components to it. So you should have been able to figure out it was either this or that, right? Hopefully you looked at it, or you will look at it. We have osteomyelitis, so I covered that on the last Zoom session. Cellulitis, which is a bacterial infection from staph or strep, so we covered that, and management. I think you guys are pretty much on your way, just ready to do some practice questions in your NCLEX book versus doing the adaptive quizzing. I would start working on doing at least 30 questions a week from NCLEX to get accustomed to how the questions are written, but at least understand why the answer is the right answer. Does that make sense?
Will we get a blueprint this test and the following and all the remaining tests, or was that just the first exam type thing?
I believe that was a first exam type thing. I can't speak on it. I personally won't be sending out a blueprint because that's a level coordinator decision. That's up to Ms. John.
Okay.
However, the one thing I will say about the blueprint is if it doesn't match what your exemplars are, I know several students were kind of concerned because the blueprint was sent out didn't match what the exemplars had. And I don't know if that, and they had previously decided not to do blueprints for second and third level.
Okay.
So I can't speak and say whether she will do it or whether she won't. But in my opinion, if you're doing the raising the bars, I think you should be A-okay. I honestly do. So hopefully you started those. And if you, I posted up the raising the bars already for fluid and electrolytes and for cognition. I don't have a coping one, but if I come across it, then I will post that. But I've been all through my emails to see if there was, if I saw a coping one. But after this one, I don't know if Ms. Johns is going to continue doing the raising the bars and do it for exam 4. I don't know. But if you're following the same pattern, you can use the same pattern that's already been put out there and apply them to your exemplars. Make sense? Okay. All right. If there's no other burning question, I mean, unless you have something you want to discuss further.
I don't know what questions to ask. I've been reviewing the material. Nothing's necessarily popped up, but I don't know.
Okay. You didn't ask questions the last time either, I think on exam 1.
I mean, for the most part, I'm really trying to just wrap my head around what the exemplar is, what's the signs and symptoms, the interventions of it. And what I feel like this exam is, the first exam I felt was more memorizing. And this one I feel like all the exemplars and the signs and symptoms become a little bit self-explanatory.
Okay.
Or like if you start thinking about what the condition is, you can kind of think of what the signs and symptoms are.
Okay.
I mean, so I don't really know what questions to ask, or if I like to think that I've got the right information. So I don't know.
In order to take any of these exams from this point on, you got to know what the common signs and symptoms are, the most frequent signs and symptoms that are seen. So if you don't know that part, then you're going to be behind the 8 ball because you're not going to know what it is you're treating. Does that make sense? Mm-hmm. So if there's something that's like a hallmark sign, then you must know that one for sure. You see what I'm saying with that part? Then you go on to the next piece. So yes, you want to know how is it managed? Is it antibiotics? These specific lab values that you want to look at the lab values is going to help you determine what it is and what you need to treat. So if you're on that path, if you've been doing that, and that's how we tried, how they tried to set the raising the bars up in the first place. So that way you would be familiar with those. And if you're chunking them in kind of how it's written out on the form, then you should be fine. But you got to know what they are. So from this point on, you have each week you need to be on those raising the bars every week. Not that I'm not saying no one's not doing that, but if you're on top of those, then it makes things go a lot easier and better. And don't forget about the immunization schedule that I talked to you guys about in class. I can't remember if I mentioned it on the last Zoom session, but just, up until the first year, because after that first year, the cdc.gov, then it starts changing. Don't look at makeup schedules. Makeup schedules are not the key component. They're looking at regular schedules, non-makeup. Okay. So don't forget about the pediatric side. There are some crossover components because of asthma is also seen in pedi. It's also seen in adults, right? And then we had the labor, but it's all shortness of breath. So remember, for that person, for the laboring mother, you have them cup their hands in order to help with their process, to kind of re-inhale, for lack of a better word, their CO2.
I have a question.
Okay.
On the pharmacology list for the exemplars, it mentions potassium for like DKA, metabolic acidosis. Don't they already have high potassium?
I don't know if they have did I see hyper or hypokalemia?
So metabolic acidosis, they
have hypo because they're getting rid of it.
I thought alkalosis was low potassium.
Yeah, I thought so too.
No, they have lactic acids. So that's going to be lactic acids that's elevated.
Lactic acid is elevated in what?
In DKA. They have ketones and acids. So it's not a potassium. So let me just make sure I'm not saying that.
Well, it's just on, I don't know if you can see this. Like it just says on like the pharmacology exemplar. I can't see myself to see if I'm showing you this or not. It just says like potassium is on here for
treatment?
Yeah, or for the medications to know.
For DKA.
Mm-hmm.
Okay, but that's not okay. What that's related to, when you have high glucose, then they have a regimen to help them pull off or help the person get rid of the glucose. It's like they give them insulin and let me make sure I'm saying it right. So they have high glucose. They have
because as soon as you start giving insulin, it pulls the potassium back into the cell,
right?
So that they run the risk of falling. So you have to know their potassium level. So that's why they may administer potassium with the insulin.
Yes.
Okay.
And I was like, well, make sure I'm saying that right. I want to make sure that I'm not telling them the wrong thing, because they give them the insulin to help pull it.
Mm-hmm.
But if you pull it too far, then you have to replace.
Okay.
So they're always going to be monitoring their potassium levels as well as what their glucose level is. So they'll start them on that insulin drip, but they're going to also, sometimes if it's high, then they're going to use it to pull off and then just manage.
Okay. So. And then for our respiratory acidosis or drug overdose patients, Narcan is the opioid antidote, right?
That is correct. So if they have any opioid, Vicodin, Norco, I did say heroin, morphine, then all of those can be given to actually block that receptor, and it will block the effects of that drug. And then depending on what they receive for anesthesia, then there's different types of medicines for that.
And that would be like the Romazican.
Right.
To bring them out of anesthesia.
Correct.
Okay.
So just understand, if you have somebody in surgery and if the anesthesiologist, whether it's a CRNA or general or MD, if they over-medicate the patient, then they're going to have respiratory or hypoventilation, or their respirations are going to be compromised. Therefore, they're going to give them an antidote to block the receptor, so that way they're going to come out of either anesthesia or become more awake. But to just understand that that's how they use it. And then as you move on in your career, you'll understand a little bit more that even if you do have a heroin patient and you do give them Narcan, they can still become unconscious as time goes on. It's not a one dose and it lasts forever. So you still have to monitor the patient continuously for the respirations until all of the heroin clears the system. Same thing for morphine, same thing for any of the others. So.
And then with our gas exchange patients, pretty much any cough suppressant is ruled out because you want them to be able to cough, right?
If anything, we're encouraging them to cough. Unless it's a smoker, then they may need something to help them expectorate. So they may end up with an expectorant, not necessarily a suppressant.
Okay.
Because those two things, they're not the same. A suppressant is going to stop the coughing. An expectorant should help get all that out.
Loosen up the mucus and trying to cough it out.
Right.
But what if the cough gets very uncomfortable for the patient?
They actually, are you saying to give them, what do you mean by uncomfortable? Does it hurt to cough?
Just keep on coughing, like continuously, like very serious spasmodic coughing. What are we going to do?
Okay, so if a patient's already coughing uncomfortably, is that what you're asking?
Yes.
Not if you give them an expectorant. Is that what you're trying to say?
That I want to know if are we saying that we never give a COPD person a
She didn't
cough?
say COPD. She was talking about asthma.
Okay, asthma. Okay.
She wasn't talking about COPD.
Okay.
That's why I was wondering, how were you asking the question? Because we were talking on the asthma side.
Okay.
But what's your question about COPD? Because I don't want you to think like I'm shutting.
No, I get it now.
Oh, okay. Yeah, we kind of covered COPD a little bit ago, but if you have a question about that, by all means.
Mm-hmm.
If ever you do want to encourage a patient to do coughing and deep breathing exercises, but that cough in, say, a chronic bronchitis patient or an emphysema patient, say that cough does get so irritating and whatnot, would you you still don't go the cough suppressant route, but you would maybe give a steroid to decrease whatever signs and symptoms they're experiencing?
Okay, so while we're trying to work with the patient in the acute phase, we're going to encourage them to cough, okay? If they're so uncomfortable or whatever the case may be, then they can prescribe something. It's not going to really suppress it, but it'll help minimize some of the irritation and make them a little bit more comfortable in coughing. Does that make sense? Mm-hmm. So it's not like it would be your go-to thing. It's only if your patient is really struggling.
Like so far exacerbated and
right. I mean, there'll be other things that's going to be priority, like making sure your patient has an airway. Mm-hmm. So I'm not minimizing the coughing component, but I don't want you staying so focused on that you miss all the other pieces. So, we want to make sure that they can cough, they can expectorate, they can get stuff up. And if they need a little bit of assistance, so be it. But all of that's going to be dependent on your patient and how they present. So just know if you need it, it's kind of a bunch of tools in your toolbox. And now you can I have this in my toolbox, I can pick it out and use it. That's kind of what all of this is about. So just know that if your patient is uncomfortable, then and it's persistent, then you can give a little bit of something before they eat or before they go to bed.
Okay.
So, but you don't want to give it to them as a means of, okay, well, you're coughing so much, so I don't want you to be coughing anymore. So we're going to give you this cough suppressant. Does that make sense?
Yeah.
Okay. So what other question I have? So you guys should be ready, right? Yay! Got to start getting excited. You can't be doom and gloom. Mm-hmm. He's like, oh no. By now, hopefully today you should kind of be finishing up your studying. And tomorrow you should kind of just be on chill mode and just reviewing, not trying to do that real hardcore studying. All that should have been done prior to today. So that way, Monday, you get to bed early tonight. You're not up to 2, 3, 4 o'clock in the morning, but you get to bed early. And then you get up and you eat breakfast and you just be ready to go. You should literally walk into the test saying, I'm ready for this test. Let's get it going. That's how you should be. So if you did the raising the bars and you've been studying them all along, then that's how when you get to the test, you're feeling more comfortable. There's always going to be anxiety, but you should be comfortable in your knowledge that it's all that you can do at this point. So if you're like, oh my God, hitting the panic button, and I'm trying not to get you guys panicking because I'm trying to kind of dispel all of that. So that way you don't get to the test and psych yourself out and then be upset with yourself later. I knew that, but I was so freaked out that I just couldn't think of an answer at the time. So you have to be able to concentrate. So that's why I'm like, study as you go. So that way you don't have that big rush, like, oh my God, I don't know what I'm going to do. So, and that's why I try to put out the raising the bars early So you can work on those and have it ready to go and all of that. Any other questions? I know there's some new folks that just came on. Not sure if you have a question or not about any of the exemplars. But remember, you still have the PD exemplars too. So we're not negating any of that. Nobody? Say what? Well, I mean, it's almost an hour. So it's not as long as the first one. And I'll, wait for it to download, and I'll post it up underneath the Zoom session in each of your course boards. So if I'm missing anybody, by the way, on emails, the only way that I can fix that is, and this now that I know, because I think there's 1 or 2 people that weren't getting the emails, then I have to send them out as, all student users versus sending them out as the group. So if I send them out as the group, then you don't get it. If I send it out as individual users or student users, then you do get it. So I'll just remember to do that so that way no one gets left out of anything. But yes, raising the bars for exam 3 are already posted. So. Well, if there's not another question or a concern or anything of that nature, then I would say we would be done. Yay? Nay? I mean, I'm free to stay the extra 30 minutes. I am okay. My schedule's clear, so I'm not rushing off like I have something to do. But I'm just wondering if maybe you all need some more time to look at the material.
Oh, yes.
I have a question.
Okay.
So if someone is experienced like an allergic reaction due to like air pollutants or something like that with their asthma, as a nurse, are we able to give them epinephrine, or do we have to get a doctor's order first?
Okay, the 2 different conditions. Asthma is asthma and allergic reaction is allergic reaction. Having asthma will more than likely complicate their problem. So I would treat the patient from the allergic reaction standpoint first. Does that make sense? Because the person isn't having asthma unless their trigger is allergens, like if their trigger is an allergen, so dust or pollen, then if they're not having hives or urticaria or they don't have any welts, so they're not breaking out and they're not having an anaphylactic reaction, then that's the only time you give epinephrine. So allergic reaction and anaphylactic reaction is 2 different reactions.
Okay, that makes sense. Well, in an anaphylactic reaction, do you need a doctor's order?
There's EpiPens beforehand. So are you saying if they're having an allergic reaction right there in the unit, then hopefully if your physician knows that your patient's allergic, then you would give them epi. But the answer would be you would open the crash cart out and give them the darn epinephrine and be done.
Got it. Okay.
So that's, if you're in hospital, that's what would happen. Hopefully they would already know beforehand. But anaphylactic reactions are usually from things like medications, latex, foods, so like nuts, peanuts, those types of things. Not necessarily environmental. It's more like bee pollen. So it's things that your body has already built up antibodies to. So when you have that repeat exposure, it continues to build those antibodies. But when it hits your body, then your body tries to attack it and get rid of it really quickly. So that's completely different than having an allergic reaction or having an asthma attack from allergens. Does that make sense?
Yes.
So you can have like a contact dermatitis or allergic reaction because, you know, like some people are allergic to Tide. So if you put Tide in your clothes, then you put it on, then your skin will break out. But that doesn't require an EpiPen.
Mm-hmm.
But if you are allergic to, you know, pollen, dust, etc., then you may not necessarily have asthma. It may just be that you're sneezing. And then you may have changes in the humidity for which now your asthma starts to flare up. So you can have a cold, the flu, allergies like seasonal allergies, and then also be an asthmatic person. But those things prior doesn't equate to an anaphylactic reaction. But that's a good question. Yeah, anaphylaxis is completely different. That's do or die. Anything else? Nobody? Two minutes. In 2 minutes, it'll be 6 o'clock.
When it comes to asthma interventions, so your medications, when it's like an acute asthma attack, like bronchodilator, something to open up those airways, and like supportive, like, or supplemental oxygen. Is that really kind of the focus of the interventions for asthma?
Right.
And then
First thing you're gonna do is give them a beta-2 agonist medication. Beta-2 works on the respiratory receptors to cause bronchodilation or to relax the smooth muscle. So you're going to give them extra oxygen. That is true. More than likely non-rebreather versus nasal cannula, depending on what the patient's oxygen sats are. But your patient may have already started their rescue inhaler. And it's usually then when the rescue inhaler doesn't work that they will now require nebulized treatments.
And just because their rescue inhaler doesn't work, that doesn't mean their status asthmaticus exacerbation is just
it just means that what the exacerbation requires more than what their multi-dose inhaler is providing.
And they're educated to say basically you can only give yourself so many puffs before you seek medical attention, right?
I don't know if you could say do 1 or 2 or 3 puffs, but most patients, you do want to educate them on knowing what their triggers are. So they should keep a log of what things trigger their asthma to come into play, including stress. And then the next thing you do is encourage them to use their rescue inhaler. If they're exercising, use it before and after, just to make sure that they're giving themselves the best possibility or minimizing a flare-up in the first place. Let's go there. So if you notice, and some people will wait, they will not go immediately. So it may happen over 2 or 3 days. They've been using their rescue inhaler and they have not gotten better. And by then, that's when they'll usually seek help, going to the emergency room or Care Now or whatever it is to get a nebulized treatment. That nebulized treatment, they usually start with albuterol. Sometimes they have albuterol and ipratropium, which is Atrovent, because the two together gives a better bronchodilation than separately. And so from that standpoint, then, they'll either, they're going to receive a steroid because 4 to 6 hours afterwards, they're going to have a rebound effect. and we want to have the anti-inflammatory on board, so that way the patient can actually heal, and it will help decrease the strength of that rebound. And for your folks that have been admitted or in things like that, it will also help to decrease admissions. So that's the reason why we're going to do that. So up until then, in the acute phase, our only goal is to get the airway open. So those three things, oxygen, bronchodilators, and a steroid. And if they're seriously bad, then they may do an ABG, chest x-ray. That will be your diagnostic studies, and pulse oximetry. So all of those would be your basic management. If you had a COPD patient, it would be the same management. You would give them oxygen is needed. You would give them, and if their oxygen sats are 92 and above on a COPD patient, you're doing good. You're doing good. So we don't need to, blow them up. But they're going to get a bronchodilator, and then, whatever else, chest x-ray, they may need an ABG. So they share some of the similar management styles between the two disease conditions, between COPD and asthma.
And so you would know your patient's a status asthmaticus patient when their respirations are super low because they're not getting any kind of airway.
Right, nothing's working. So you're doing everything, but minimal effects are going down. And don't forget about peak flow meters, and what does it mean, the colors and the numbers and what they all mean.
You're talking about the colors like the red, yellow, green. Mm-hmm. And then you said every asthma patient needs to have an asthma action
plan. So know the 4 different action plans. It's listed in Lewis, but I actually talked about those, I think it was last week or in class. So not this week, but the week before.
Okay.
So, they have a 1, a 2, and a 3, and a 4. So one was the asthma categories. So number 1 was intermittent, 2 was the mild persistent, 3 was the moderate persistent, and 4 was your severe persistent.
And really what you need to know about those is like how often they're disturbed by their asthma when their symptoms pop up.
Right. Are they up at night? Does it interfere with their normal activity? What's their FEV? So, you're kind of looking at how their asthma is progressing or operating, for lack of a better word. So do I have symptoms more than 2 days a week? So, am I a person that I'm dealing with my asthma issues, every day? So if I have an asthma problem every day, then I'm not going to be a mild persistent. I'm going to be a moderate persistent. Mm-hmm. If I have symptoms less than 3 days per week, then I'm going to be an intermittent. Okay. If I'm using my short-acting beta-adrenergic medication less than 3 days a week, then I'm going to be intermittent. If I'm using that greater than 2 days a week and I'm having symptoms greater than 2 days a week, then I'm going to be an intermittent, a mild persistent, not an intermittent. I'm going to be a mild persistent. So the 4 stages is the first one's intermittent, all the other ones persistent, mild, moderate, severe. So if I'm going to learn it like that, then I know that I have 3 persistent ones and 1 intermittent.
Mm-hmm.
So yeah, you got to know the asthma plan, have it in place. Talk to them about their triggers, talk to them about their peak flow meters, when to use it. And just keep in mind, no matter anytime, whether you're testing for ECC, or HESI, or for NCLEX, always assess before you do something. So if in the stem of the question it gives you your assessment, then okay. More specifically, if people are having pain, you want to make sure you go in and you assess the pain. Your UAP comes out and says, hey, Mr. Green's complaining of pain, or they ring the buzzer and they say, hey, room 3's complaining of pain, then the next thing you need to do is assess the pain. You can grab the medication if you so desire on your way going to the room, but before you give it, you need to do an assessment. But the answer should always be do the assessment first. But just to save in clustering care, you can grab the medication beforehand. So, and then talk to them about not letting the pain get so bad. Anything else you want clarification on? All right. Well, then I'm gonna let you guys go and do some hardcore studying. Make sure you eat and get some good rest. Trust me, all those things help. You think they don't, but they really do. It allows your mind to think a lot clearer. But don't stay up all night to take that test and to be there at 7:30 in the morning. So always give yourselves the best opportunity to be successful. Got it?
Thank you.
All right, guys. We'll see you Monday and Tuesday.
Thank you.
Thank you.
You're welcome.
Thank you very much.
Okay, bye-bye.